Hello, ladies and gentlemen. My name is Jordi Merchan Bravo. I study University Católica of Santiago de Guayaquil. My topic is reducing intensity Rivaroxaban for the prevention of the recurrent venous thromboembolisms. Definition of the case. Patients which provoke venous thromboembolism (VTE) are at risk for recurrence. Although Rivaroxaban is effective for extended VTE treatment at the dose of 20 mg daily, usage of the 10 mg dose may further improve its benefit to risk ratio. Low usage experience also reduces rate to the recurrent VTE but has not be compared with anticoagulant therapy.
Venous thromboembolism, or VTE for short, is a leading cause of death worldwide. In the Western world, someone develops a VTE every 16 seconds. Manifestations of the disease are deep vein thrombosis and pulmonary embolism. The disease process starts, often in one of the large veins of the leg, with the formation of a blood clot. This can be due to vessel walls, a pathological increase in the coagulability of the blood, or circulation deficits. The resulting blood clot consists mostly of red blood cells, held loosely together by strands of fibrin. There is a considerable risk of such a fragile clot or parts of it breaking away and traveling with the bloodstream through the heart and into the lungs. Here, the clot or fragment of clot eventually blocks a pulmonary artery. The consequence, pulmonary embolism. The affected area of the lung is no longer available for the oxygenation of blood. This life-threatening outcome can be traced back to an inappropriately triggered physiological process, blood coagulation. Various medical conditions are associated with disrupted blood coagulation and therefore an increased risk of VTE. For instance, immobilization heightens the risk of hypercoagulability of the blood and venous stasis. Patients undergoing major orthopedic surgery, such as total hip or knee replacement, have an additional risk of vascular injury.
Application in medicine. The Einstein study is a multicenter, randomized, double-blind, activity-controlled, event-driven study comparing the efficacy and safety of 2 ounce daily doses of Rivaroxaban 20 and 10 mg, which experienced 100 mg daily. For the prevention of the recurrent VTE in patients who comprising 6-12 months of anticoagulant therapy. For their index acute VTE events, all treatment will be given for the 12 months.
Cancer patients are at really high risk for getting blood clots, and once they get a blood clot, it's actually very impactful on their clinical course. So they're more likely to have morbidity, swelling, pain, more likely to be admitted to the hospital, more likely to need anticoagulation for almost an indefinite period of time, and it's the second leading cause of death in patients with cancer. So after cancer itself, thrombosis is the second leading cause. So it certainly is something that needs to be prevented. The challenge has been that the risk for getting blood clots is very variable amongst cancer patients. So there's some cancer patients that are at really high risk and some patients that don't have that much risk. So the reason we did the study was to pick just the high-risk patients, and we picked them based on a risk score that we had developed a few years ago. And only the high-risk patients were randomized to receiving deltapirin, which is a low molecular weight heparin, versus observation. The study essentially proved that, first of all, the high-risk patients were at really high risk. So 9% of them had a blood clot even before they started on chemotherapy. And an additional 21% in the observation arm developed a blood clot over the 12-week period, which is not that long to get a blood clot. Yeah, so the risk score is a very simple score. It takes 5 simple clinical and lab variables: the type of cancer, the components of the complete blood count, so the hemoglobin, leukocyte count, platelet count, and the BMI. So it's all really simple stuff that every cancer patient has. We published this in 2008, and since then it's been validated in over 13,000 patients. So it's been studied sort of left and right, and every study that's looked at it in a careful way has been able to validate it. So it's accepted by ASCO as the only validated risk assessment tool, and it's great because it uses these simple variables, and you can really identify high-risk patients very quickly. So the take-home message is there are some cancer patients that are really high risk for blood clots, and that risk is preventable. So identifying them partly by screening. So if somebody has a score of 3 or higher, maybe you should be looking at the lower extremities, making sure they don't already have a blood clot. And partly by using prophylaxis, preventive therapy. And at least educating patients, making sure they understand the warning signs and symptoms of DVT and PE is really important.
Pros and cons. The primary efficacious objective is to determine whether bulk doses of Rivaroxaban are superior to aspirin for the prevention of the symptomatic recurrent VTE, while the principal safety outcomes is the incidence of major bleedings. The trial is the anticipated to enroll 2,815,000 patients from 213 sites in 31 countries over the period of 27 months. Conclusions. The Einstein study will provide new insights into the optimal antithrombotic strategy for extended VTE treatment be compared to doses of the Rivaroxaban with aspirin.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves 2 pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the 2 pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A, in combination with 5A, activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor Xa in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
Thanks.